Okay, so we're going to talk about autism as a neurodevelopmental disorder. So according to DSM-5, irrespective of what you may think about it, it is one of a group of neurodevelopmental disorders. And I'm going to try to give you some sense of what it means to be a neurodevelopmental disorder, what they have in common. But you can see it's a broad collection of syndromes that includes autism spectrum disorder, but also intellectual disability, learning disorders, language disorders, but also, interestingly, ADHD and some movement disorders. Now, I would argue that DSM-5 didn't go far enough, and that in fact there are a number of other disorders that should be thought of as neurodevelopmental disorders. And why this is important is because some of the symptoms overlap between these different disorders. But OCD for sure, mood and anxiety disorders probably, and almost certainly schizophrenia and even Alzheimer's disease. And why do I say that? Because I think there's growing evidence to suggest that people at risk for Alzheimer's disease, at least some types, may actually have some of the early symptoms of disorder in childhood or adolescence. I know that seems shocking, but it's particularly important given that we're thinking about how do we identify these disorders early and then have early interventions. So, autism, as I mentioned yesterday, like most medical conditions, is a syndrome, which is a group of symptoms that tend to cluster together and share a common natural history. They tend to cluster together. They don't always cluster together. They may vary somewhat. In contrast to a disease, a syndrome is a disease is a syndrome for which there is a known etiology or pathophysiologic process or both. Now, ADHD, ASD, but also intellectual disability and other neurodevelopmental disorders are really not unusual medical conditions. They're heterogeneous. By that I mean because some have some symptoms and some have other symptoms, and they're not exactly the same in all patients. And furthermore, many of the symptoms are not unique to the disorder itself, but are shared by other conditions, often conditions within the same rubric, that is, other neurodevelopmental disorders. And as I mentioned, they're very similar to things like diabetes, asthma, etc. And then for most of these disorders, the reason we don't know the etiology of the pathophysiologic process is because it's complex. And it's complex partly because the pathophysiology is complex, but also complex because of the clinical heterogeneity and clinical phenotypic presentation. So when we talk about autistic spectrum disorder or autism, whichever term we want to use, and by the way, I think there's one really sensitive point that, this is a digression. I never call someone an autistic person, or you are an autistic, or they are autistic. They're a child with autism, an adult with autism. This is an important distinction, and I think that, and its reason it's important primarily to the families and the kids, because they're kids first, or they're adults first, and by the way, they're not defined by their disorder. They have other characteristics that are equally, if not far more important. They have likes and dislikes and unique characteristics and senses of humor, and we need to respect that before we make them become their disorder. Now, autism, like many disorders, has some similar characteristics across all individuals. They're the two Ds that I refer to, developmental delays, that is, things don't occur on time, delayed speech, sometimes delayed walking, some other activities. And then they have developmental deviations, behaviors or things that don't appear in other typically developing individuals. And again, I use the word typical, not normal, because development doesn't follow a normal distribution from a statistical point of view. So some things are just different. So spinning, rocking, some of the stereotype behaviors just don't appear in other children. The domains of impairment are primarily in the area of social development and social functioning, which include things like social reciprocity, theory of mind, and problems with joint attention. This is often reflected in difficulties with communication, and then there's a third set of characteristics that are called restricted repetitive behaviors and interests, and as well as activities, and now lumped under that is also perhaps some sensory atypicalities. The course, though, for autism and autism spectrum disorders, importantly, is consistent over time. That is, most people with ASD get better. over time. Some symptoms decrease quite dramatically. The stereotypies, repetitive behaviors tend to decline, and the difficulties with visual regard, looking at faces, tends to improve over time. Remind me, if we have time, I'll come back to later the issue of whether people with ASD look you in the eye. They do, but it's somewhat different. Now, but some of the symptoms persist over time, particularly the difficulties with social reciprocity if they have a language deficit, and some of the restricted or repetitive behaviors or insistence on sameness, the need for things to be predictable and the same. Now, interestingly enough, DSM-4 and ICD-10 had very similar categorizations for autism or in the related disorders. In DSM-4, they were called pervasive developmental disorders, and there was a different category in ICD-10, but they were almost coherent with one another. And this is unusual between ICD and DSM for reasons that are political rather than clinical or scientific. And in fact, the diagnostic criteria themselves were identical between DSM-4 and ICD-10. No one has a clue what ICD-11 is going to look like, and we know what DSM-5 looks like. But there was a general agreement. Now, this is important because it means that across the world, there's a general consensus about what the diagnostic criteria are for this syndrome, not disease. And you can see them. And if those who were here yesterday, they look very similar to the ones that the NSAC, the parents had the scientists create in the 1970s. So the criteria haven't changed a great deal. One of the problems with the DSM-4 criteria, however, was if you look at the diagnoses going horizontally, if you look at autism, Asperger's, and then the different characteristics, reciprocal social behavior, language, cognition, restricted repetitive behaviors, even at a phenotype level, a behavioral phenotype level, it was very difficult to distinguish the different elements of the DSM-4 disorders. And as the etiologic studies were taking place, particularly genetics, there was no genetic pattern that, or for that matter, imaging or other patterns that were unique to one of these categories. As a result, for diagnostic reasons, they lumped everything in their autism spectrum disorder. That is, there was no evidence that the distinction among these subcategories made any sense, but simply reflected the heterogeneity of the disorder itself. And so these are the principal diagnostic criteria. There are two main criteria: the persistent deficits in social communication and interaction, and then restricted and repetitive behaviors. They combined elements. And then they added two components. Why am I covering all this? Because if you're going to do an assessment, you have to know this stuff. They have specifiers with or without loss of established skills or regression, etc. And associated with a known medical or genetic condition, which would allow you then to keep Rett syndrome, and so we don't have to give it away to the neurologist. And then they also created specifiers for severity. They did this for all the disorders in DSM-5. There's no empirical basis for this, and there's actually no standard measure for severity. And so this is not necessarily empirically based, and one which one has to take with somewhat a jaundiced view. Now, what do we really mean when we talk about a spectrum? I think it's a really important question, and partly it's important because I see you taking pictures. It's fine with me, I don't mind, but I've actually given the organizers a PDF of the slides, and they'll give them to you, so you don't have to do all that hard work. Okay, it makes your life easier, right? Try to make your life easy. But anyway, what do we talk about a spectrum? That is, there's a continuity of the symptoms that range from quite severe to quite mild. And there are four major areas in which which constitute the spectrum. The first is the idiosyncratic behaviors associated with ASD, restricted repetitive behaviors and insistence on sameness. The second is the language capacity, more or less fluent. The third is the quality of social skills. And the fourth is cognitive functioning, which is a confound in this disorder. So if you have fewer symptoms and higher cognitive functioning, you're going to be on the higher functioning side. But there's a spectrum, and so you can end up in one of the quadrants depending on which skills you have and don't have. This is just really like any other disorder, psychiatric or medical. Depending on your adaptive functioning, you have higher or lower functioning in general community outings, but it doesn't mean you don't have skills in one area and may not have skills in another. So there's variability in the skill level in specific elements, but when we talk about high and low functioning, we really talk about it in a general adaptive sense. And really, how close it is you come to looking like typical people, whatever typical means. And that varies. Okay, so I talked about associated with known medical or genetic factors. So, and for the first time in DSM-5, we can now have comorbidity with other psychiatric disorders, neurodevelopmental disorders, and this is particularly important when we're doing diagnostic assessments because a great number of individuals have attentional problems, they have stereotyped repetitive behaviors like OCD and Tourette's, and you wouldn't be surprised to hear that many would have mood and anxiety disorders just from a straight epidemiologic perspective, but also from the perspective that this is a tough condition to live with and you may have symptoms. So we have to evaluate and code those separately. So this is just to show you very quickly people who are worried about what happened to Asperger's syndrome. If you go and look at the criteria, the different elements went to the A criteria, so in green are the DSM-5 criteria. So A went to A in DSM-5, and then these others went to B1 and B2 and B3 in DSM-5. They're all still there. None of the symptoms went away. Then another way to look at it is basically the B and C criteria became part of A, the D criteria became part of B, and the A criteria became part of C. And everything stayed together, and so it wasn't a big change. And then they added social communication disorder, a disorder for which there's not really a substantial empirical base, but it's essentially people who have language deficits that interfere with social functioning. And they don't have restricted and repetitive behaviors. They don't have the B criteria. So you have to know this now because you're doing evaluation, you're going to arrive at a diagnosis. Now, I have a quiz, and everybody has to participate. So, all right, wake up for those of you who are snoozing after your coffee or drinks or whatever. All right, these are 6 individuals. I'm sorry to say that we've asked them to do one thing, and that is to pretend like they were going to shoot a gun. Okay, I would prefer something else, but just something that would be easy to identify. So we're going to go and start number 1, 2, 3, 4, 5, 6. Now I want you to raise your hands and tell me which one of these people has autism. Are you ready? Number 1. Does number 1 have autism? Raise your hand if you think he does. Okay, we got 1, 2. Okay. Number 2. Who thinks number 2 has autism? Okay, good. About a third of you. Number 3. Do you think he has autism? No, nobody thinks he's got autism. What about number 4? This is a girl, actually. She's got the commando stance here. What about her? Does she have autism? Huh? Yeah. Number 5? Who thinks he's got? And number 6? Okay. All right. You all fail. Well, they all have autism. I heard somebody yell it out. You knew it was a trick, right? Okay, so the deal here is you can't look at static behavior and decide whether someone has autism. It's a disorder of reciprocal social functioning. Looking at a picture doesn't tell you a damn thing, okay? So guess what? You have to examine people in order to figure out whether they have autism to make a diagnosis and do a proper assessment. Assessment is a multimodal, multidisciplinary process. What are the processes? You have to be aware that ASD could exist. You do some screening to look at whether some of the symptoms broadly exist, and then you do gold standard. Someone objects to the term gold standard. We can make it a silver standard or platinum standard, whatever you want, but a standard diagnostic assessment that's evidence-based. And then we do treatment planning, and then we do treatment outcome evaluation. It's not good enough just to plan a treatment. You have to know what your likely outcomes are so you can see if it works. And then another part of assessment is dealing with public policy we'll talk about later. Who are the team members? There are tons of people on the team who do this. Screeners, primary care people, teachers, parents, nurses. Make a list. And who are the evaluators? Well, psychiatrists, neurologists, pediatricians, psychologists, speech and language pathologists, behavior therapists, geneticists, and many other people. It takes a village to make a diagnosis. And then it takes people who can provide treatment. So this is not a simple process, it's a complex process, and it takes time, and it takes knowledge, and it takes energy. Okay, what are the sources of information? We already mentioned screening, I'll come back to that in a minute. You have to do a clinical interview. Yes, it means you have to bring the child or the adult into your office, and you have to spend time with them. I know that sounds shocking. In this day and age where you think you could go to the waiting room and make a diagnosis, you can't do it. You have to take a history in some sort of structured way and conduct a mental status exam. Oh, and by the way, I know this is a shock, but you have to do a careful physical examination as well. And many psychiatrists in particular have forgotten how to do physical exams. They need to relearn it or they shouldn't be working in this area. And that means a careful neurologic exam and a sensory exam. About once a year, we'll see a child in our clinic who is brought in because they have ASD, and in fact, they're deaf or they're blind or both. And it's really hard to be social as a 2-year-old or an 18-month-old if you can't see or hear. And if once you fix that, it's amazing how much more social they are. We also do standard diagnostic assessments, I'll talk about those in a minute, and psychological testing, and measures of adaptive functioning. So it's not just sufficient to say someone's IQ is this and they have these symptoms. You have to know what they can do with those symptoms and how impaired they are. And then I'll talk a little bit later about laboratory testing. Now, if you're going to do a diagnostic assessment, it seems to me you need to know what the risk factors are and what the things that are most predictive of bad outcomes so that you can make sure you check for those. So as an example is language. So if a child has no social smile or expression of joy by 6 months, there's likely to be a problem. And if they're not sharing sounds, smiles, or facial expressions by 9 months, there's likely to be a problem. Does it mean that there won't be, that it's for sure, or that you can wait and look? You can't wait. And you're never for sure, but boy, these are serious warning signals. A child that's not babbling or using reciprocal gestures by the age of 12 months is likely in big trouble. 12 months, no response to their own name. 16 months, no words. And 24 months, no meaningful two-word phrases that are independent, not echoed. These are profoundly serious signs that something is developmentally awry. Does it mean that they necessarily have ASD? No, but you can bet that they have a neurodevelopmental disorder, and you'll be more likely right than not. So understanding normal development and developmental variation is a critical part of the diagnostic assessment before you do anything fancy. And it's really important for us to make early diagnosis because there's evidence to suggest that it will be, earlier the intervention, the better the outcome. There are some very early findings that are developing now, and the most significant of these are the eye tracking findings by Ami Klin and his colleagues now at Emory. And they've shown that children with ASD who later develop ASD have a great deal of difficulty with social eye tracking, and I'll show you an example of that in just a minute. And that eye gaze and visual regard is a critical role, it plays a critical role in all this. Okay, there are a number of screening instruments that are available for ASD that can be used in the community, in clinicians' offices, and even in a psychiatrist, psychologist's office in anticipation of a patient coming in. I've listed 10 of these. Is any one particularly better than the other? Well, they each have characteristics that are good and bad, and none of them is not adequate. I was actually terribly impressed by the presentation yesterday about the PEP. The PEP, was that what it was? The 10 item, huh? Yeah, the 10 items. The shorter it is, the more likely you get people to complete it. If they don't complete it, then it's not a very good screening instrument. And most of these are way too long to get them done routinely in other settings unless you have investigators or nurses who are committed to getting it done. In general, I think if you really want to do serious screening, you have to have people who are dedicated to go do the screening, not just rely on parents to fill it out in the training pediatrician's office. The gold standard for diagnosis for ASD is are two clinical examinations. One is the ADI-R, which is a structured clinical interview for taking a history. The second, completed conjointly, is the ADOS, the Autism Diagnostic Observation Schedule. The two of them together provide more than ample evidence to support a diagnosis, but I want to be clear, they do not make the diagnosis. It also requires the incorporation of other clinical data. And with the toddler ADOS and the adaptive ADOS, now the ADOS really covers basically the entire lifespan so that we can evaluate individuals from about a year of age all the way through adulthood. and even if they have intellectual disability associated with it, and whether or not they have language. The ADOS is a diagnostic tool, but one part of the diagnostic process, it's a series of developmentally sensitive behaviors that are provoked by stimuli. It takes about 50 or 60 minutes to complete in skilled hands. It requires training so that you can be reliable on it. But it collects standard information about social behavior, vocalization, speech, play and interests, and typical or atypical behaviors. It is not a measure of cognitive functioning and is, in fact, if you don't use the right module, sensitive to cognitive level. How predictive is the ADI and ADOS? In a study that's been done by Kathy Lord and her colleagues, they studied 108 kids at the age of 2. This study, I'm just going to report data for the age 5. They've been now followed into their 20s. But at age 2, they were all diagnosed with ASD. They were then seen at age 5 by a different group of people. Of those, 61% still had autism. This is by DSM-4 criteria. You say 61%, that's not very good, is it? But then 25% had PDD-NOS. Oh, so that means now 86% were in the autism spectrum, what we would call autism spectrum. Of the remaining 14%, all of them had either a serious language impairment or had intellectual disability. So it is a pretty good screening instrument, a pretty good diagnostic instrument. You're not likely to be wrong in young children, and at the age of 5 or 6, the reliability and validity is much, much higher. There are many other diagnostic instruments that people use, either for screening or for diagnosis. I've listed a bunch of them here. The SCQ, which is basically the DSM criteria, the CHAT, which is a diagnostic tool, the PDD-ST is a screening tool, the Rimlin, GARS, CARS, many of which are familiar to you. Each has their strengths and weaknesses, but if you're going to do science or you're going to use a gold standard, internationally accepted, you probably have to use the ADI and ADOS, and I know there are many complaints about it. We can talk about that later. In addition, the social responsiveness scale done by John Constantino and his colleagues at Washington University in St. Louis is a 65-item parent and teacher instrument that allows you to measure social reciprocity. It is good for ASD. It is not good for measuring social reciprocity across the population, however. Now, this is work from Ami Klin, and this is a critical point that I want to show to you. The child on the right has ASD. Let's see, you're right. Yes, you're right. Has as a child who was at high risk for ASD turned out to later have ASD, and the toddler on the left is a typically developing child. Right? And you can see the toddler on the right doesn't look at the face of the child on the left, whereas the other one does. And what happens is there's growing evidence to suggest that even in early childhood, 6 to 12 months, that children differentially use visual regard to search the environment. It's not that they just avoid the face of the other individuals. They don't use the face and the facial expressions to inform them. Now, whether it's because they're afraid of them, don't understand them, is not clear, but this eye tracking phenomena seems to be quite specific to the disorder. And they've published many papers on this, and there's now a new eye tracking paradigm that's available to identify children at high risk. When we assess individuals with ASD, we also have to do cognitive assessments, and that includes both verbal and nonverbal cognitive tests. A Wechsler or a Sanford-Binet are not sufficient. Since many of these children have language disorders, if you use a language-dependent test, you're going to get suppressed scores. So in general, you need to both, your psychologists have to have a nonverbal instrument. The DOS is what we use and the Ravens, but you can Mullins for kids who have lower cognitive ability. But you must do both. And if you're want to follow behaviors, the aberrant behavior checklist is for neurodevelopmental disorders, a 58-item instrument with 5 subscales. The irritability subscale is one that's particularly important, has been the one that they've used to demonstrate the utility of some of the medications in treatment of ASD. And this is an instrument you can do repeatedly at visits to see whether they're responding to treatment. And then you have to do measures of adaptive functioning. The best known is the Vineland scales, which were normed on children with ASD, but the DABS, the diagnostic adaptive behavior scale is from an organization for people with intellectual disability, and it's a standard instrument for measuring adaptive functioning in people with intellectual disability. And then you have to do language assessments. And we have to do both expressive and receptive language. And remember, language is not just speech, it's the full spectrum of communicative behaviors. It includes gesture, body posture, facial expression, all those things. And there are a whole series of standard instruments that are available for that, and which means that you're almost certainly going to have a speech and language pathologist who knows how to do these involved with you. I actually know how to administer most of these instruments, but I wouldn't trust me doing it. I would prefer to have someone who's actually trained and skillful at it. And then we have to look at the behaviors themselves if we're going to design the treatment. And the standard format for that is a structured behavior analysis or functional behavior analysis, an FBA. It involves multiple observations in multiple settings with multiple stimuli. And then the whole idea is to identify the discrete behaviors so that one can design a behavioral treatment plan to play a role in the intervention. So just because we have a diagnosis and just because we have someone says someone has restricted and repetitive behaviors, we need to specify those because some may be responsive to medications and most will be responsive to behavioral interventions. And then there are a whole variety of other assessments that we may use to take care of someone with ASD. Certainly looking for other psychopathology using the BASC or the CBCL for sure. We do the BASC routinely in all of our kids. Some kids need psychoeducational testing for achievement and other functioning. Some need neuropsychological testing. And occasionally we use occupational therapy and physical therapy. And I already mentioned the importance of making sure the children can hear and see. And because 25% of individuals usually or older in adolescence or late childhood, develop seizure disorders, particularly if they're intellectually impaired, making sure we assess for that is important as well. And then when it comes to laboratory studies, we need to consider a full spectrum of laboratory assessments. In genetics, almost every child with ASD should probably have a Fragile X test. With the rest of genetics, it's somewhat controversial. The American Academy of Neurology says everybody should have a whole exome scan. I think that's a bit over the top and too expensive. So we generally, if children have an indication, we'll do a SNP microarray as a screening tool, and if they're positive, then we'll go on and do other genetic screening working with the geneticist. Neuroimaging at this point, in the absence of focal findings, is probably not likely to yield a finding. If there are focal findings, it's an entirely different story, and the risk of anesthesia is far greater than the likelihood of finding something, so imaging tends not to be a part of our routine anyway. EEG, again, if there's evidence of seizure activity, or you can use polysomnography if there's a sleep problem. Screening for heavy metals is only important if there's pica or evidence of other exposure. Routine immunologic testing, vitamin levels, enzymes, and the whole plethora of other things that people have thrown out are generally fishing expeditions or likely to yield misleading information. And you have to remember, if you do a lot of tests, some will turn out positive, sort of a type 1 error kind of phenomenon. You have to know how to manage those in the context of doing the assessment. And remember that families are going to come in and say, you know, I want this test or I want that test. And you're going to have to be able to understand the utility of it and the cost before you commit to it. So why do we do all this work? What's the whole point in making a diagnostic assessment? Well, certainly we want to establish a standard clinical phenotype and a baseline that we can follow over time. By making a diagnosis, it also tells us something about prognosis, and that's useful, and it creates a basis for a treatment plan. We shouldn't underestimate the value of a label in giving a family and a patient some understanding of what they're experiencing and the language for communication with other family members, with their community, and their professionals. So while we may be not entirely comfortable with a diagnosis, a label can be very important for families. And of course, diagnostic assessments are concise forms of communication amongst us. When we say someone has autism spectrum disorder, in general, we'll understand what we're talking about, and no, we're not dealing with depression or something else. It also creates affiliations for people so they can join the Autism Society or Autism Speaks or whatever they want to do. And finding that kind of social support in the community is really important for people. It makes them feel comfortable and much more supported. And of course, it's a categorization for research purposes. It establishes eligibility for services, we know about that, including reimbursement from insurance companies, and it completes administrative obligations. For those of you who have to use electronic medical records, you can't close it until you put a diagnosis down. That doesn't mean it's necessarily the right diagnosis, but at least it allows you to complete closing the record. If you don't have electronic medical records, you're so lucky. Okay. So, a comprehensive clinical assessment is usually designed to understand a syndrome, then establish and monitor treatment. It should be comprehensive, it's got to be clinical, it's usually categorical, that is, you come up with a label, it's often dimensional because we talk about a spectrum of functioning, it's always multimodal, it has to include many elements of an individual's functioning behavior, and it's almost certainly going to be multidisciplinary. It identifies both health and strengths, as well as illness and weaknesses. And it's ongoing. Assessment is an ongoing process and never-ending. And it's often correct, but not always, and we shouldn't forget that. So people are often very critical of the comprehensive developmental assessments and coming up with diagnoses. And I understand that. But I'm reminded of something that Winston Churchill once said. He said, it's been said that democracy is the worst form of government except for all those other forms that have been tried from time to time. Categorical diagnosis is the worst form of medical practice, except for all the other forms that have been tried from time to time. So for the time being, making categorical diagnosis is what we've got to do. Hopefully someday we'll have other tools that allow us to make pathophysiologic or RDocs or other kinds of dimensional diagnostic diagnoses. But for the moment, we have to go through this process and do it with clarity, with competence, and with sensitivity to the needs of our patients. Thank you very much.